Going live.
Good afternoon, everybody. I am Robert McClellan, one of the co-chairs of this Action Collaborative. Welcome, and thank you for joining today's webinar titled Coming Together to Address COVID-19, a Community's Experience. Today's webinar is hosted by the Action Collaborative on Business Engagement in Building Healthy Communities, which is an ad hoc activity associated with the Roundtable on Population Health Improvement. The Roundtable itself is a convening activity launched in 2013 by the National Academies of Science, Engineering, and Medicine. The collaborative is a flexible and action-oriented group that welcomes all interested organizations and individuals. The collaborative's purpose is to catalyze and facilitate private sector partnerships and actions of business, health, community, and the public sectors to work together to enhance the lives of workers and communities by improving the nation's health and wealth. This is the fourth in our 2020 series of webinars, a series that has pivoted due to the current public health crisis to showcase great examples from around the country. You may access prior webinars on our website, and the link to this website is in today's program announcement and will also be posted in the chat box. Our next webinar, featuring the COVID-19 response of Live Well in San Diego, will take place the week of July 20th. The collaborative webpage will have details around upcoming events. Another relevant upcoming event from the Roundtable on Population Health Improvement will be its virtual June 24 to 25 workshop on the topic of rural health. Again, see the chat for the link to the relevant webpage and registration. During today's session, please use the chat box to pose questions, comments, converse with your co-participants, and post relevant resources. I will be monitoring and bring your thoughts forward at the end of the presentations during the full 30 minutes we have allotted for discussion. Never has the relationship between community and workforce health been so clear. Today, we will hear about how long-standing collaborative efforts of the Michigan Health Improvement Alliance prepared a 14-county region in central Michigan to manage the onslaught of the COVID-19 pandemic, followed by devastating floods. I'd now like to welcome and introduce the 5 speakers who graciously agreed to come and share their work with us. Catherine Bozzi, who is the board chair of Michigan Health Improvement Alliance. Rebecca Bentley, Vice President of Global Public Affairs at Dow. JJ Boehm, who is the interim executive director of University Communications at the Saginaw Valley State University. Christopher View, who's the director of the supply chain management of Mid-Michigan Health. And George Kikano, the vice president for health affairs of the Central Michigan University and dean of the Michigan University College of Medicine. Their longer bios are posted on the website. And with that, Kathy, I will turn it over to you.
Great. Well, thank you. It's a great privilege to be with all of you today and to share a story. And it truly is a story that's relevant and I'm sure is being replayed in many communities around the country. During these times of just unprecedented challenges and what I call the co-occurring health and economic crisis that's been overlaid upon all of the many challenges that are already in our society in general, that so many of us have been working to address and overcome. This story is really the story of several counties in which we're calling our community and how we have come together. And it certainly isn't meant to say that there's no more challenge and that all is well. What it is to share is how multiple sectors coming together in a genuine and powerful collaboration are a huge asset in a community. And today's story is going to be a snapshot, not the entire story. We couldn't possibly talk about all the collaboration that has gone on in the community and we couldn't include all of the sectors that are involved. So the way we're going to walk through our story today is to just quickly share who exactly we are, that we're here talking with you today, and where we are physically on the map. And we'll go through a piece of our COVID-19 response as these multiple sectors coming together, dominantly focused on the address to the gaps of PPE and mask making and manufacturing, followed by uniqueness in our community, which is as we were moving through the daunting challenges of a COVID response, ended up with a 500-year flood in the community at the same time. And then we'll end with our way forward. Next slide. So this is a participatory effort, and we have many people, way too many to possibly include on a webinar like this, but we wanted to represent the different sectors. I myself am Catherine Bozzi. I'm from the nonprofit sector in the community. We have general business represented by Dow and Rebecca Bentley, higher education, academia with JJ Bain, the health systems themselves, representative here with Chris Vo, and then individual providers and roles that they are providing in citizens and in various other capacities, represented here with Dr. Kikano. Next slide. So who we are and where we are. So I'm with the Michigan Health Improvement Alliance, and this was established in 2007. Quite a long time ago, and it's a classic integrator or backbone organization. It's a multi-sector, multi-organization, participatory organization, collaborative, whose mission it is to improve the health of the citizens of this geography. And our signature initiative that is underway right now in partnership with the Great Lakes Bay Alliance is called THRIVE. And THRIVE stands for Transforming Health Regionally in a Vibrant Economy. This is unprecedented, big thinking, sort of radical effort that has a whole portfolio of actions which are to be implemented at scale in a sustainable way to change the negative trajectory we've experienced in terms of health and economic factors. Now, our region is in this box, the purple square, which is 14 counties. That 14 county region in central lower peninsula of Michigan has a total population of 760,000, which will indicate that some of these counties are fairly rural. The most population dense counties are in the slightly darker gray, and just 4 counties represent 450,000 of the population. So that would be sort of the population hub within this broader geography. Next slide. And as I mentioned, this THRIVE initiative has 2 multi-stakeholder organizations that are anchoring it and facilitating it. And Mahaya, which has been ongoing since 2007, has brought multiple stakeholders together across this region for 13 years. So that's the foundation and the history of collaboration on health-related needs. And that has brought together public health, the healthcare delivery systems, academia, mental health, community-based organizations, many, many partners. And our THRIVE signature initiative illustrated here is a conglomerate of numerous interventions that engage broad swath of the community who come to the table under a shared mission and a shared set of priorities. And the nature of the community partners is listed here. And I share this to sort of say, before COVID, there was a lot of collaboration going on in the community facilitated by this work, and it's the sort of culture within our region to have strong collaboration. This is an illustration of one way that there's an actual framework that facilitates this on an ongoing basis. Next slide. Just in the last 12 months of, if you can move to the next slide possibly, in the implementation, oops, we went 2 slides. In the last 12 months of our Thrive initiative, this is just an illustration of the many partners that have been involved in our 8 primary intervention actions of that last year. And you can see clearly that we have numerous partners used to working together for shared purpose. Next slide. So bringing us to the all too familiar picture of the coronavirus nowadays. Our story begins, it's hard to pick the day, but I'm saying around March 10th. March 10th was the first confirmed case of coronavirus in the state of Michigan. And even before that, the buzz had started because we were watching other areas. Oops, if you could go back, please. Go back 1 slide. The buzz was already out there with the other states and with the other geographies that were experiencing the coronavirus. I feel like we're stuck on the slides. Is it possible to move back 1 slide? Maybe we can only go forward. Okay, so back in those early days, we were really focused on a lot of sorting out and getting our feet under us, I would say, because there was a lot of conversations going on, a lot of phone calls, lots of emails where people were saying, oh my gosh, this is a big deal. This could be a big deal. How are we going to be ready and what should we do? And there were probably more points of confusion and people searching for information. So like others, the Michigan Health Improvement Alliance, or MHIA, was searching for, well, what's our role? So many people were saying, well, you should be doing something. You work on health, and health is your sort of space. But what do you do as a backbone organization in the light of a coronavirus pandemic? That's not normal. We had a lot of other things we were used to working on. So we had conversations with the county emergency managers, with the health department directors, with the health systems, and we're saying, well, what is everybody doing? What's working? What's not working? Where are the gap spaces? So there was this window, I would say, of about a week of really just level setting and sorting out roles. Okay, so what do you need? What could possibly be done to fill gaps? And really looking across the region at the assets. We were already hearing that there was a difficulty in accessing supplies, and in particular, personal protective equipment. And we were hearing that there was going to be a lot of needs for communication and a lot of different processes that would need to go in place. And so we began to assess assets, saying, okay, if this is going to be really hard, and testing was really difficult at that time. I think in the earliest days, the state lab could process some very small number of tests per day, like 30 per day. And people were concerned about testing capacity. So we began to assess assets, saying, okay, this is PCR. How many PCR machines are in our region? Who's got them? Let's identify them. And we began to assemble an asset registry of what capabilities do we have that we could bring to the gaps that were being identified, and began to put together literal lists and inventories of all the things that could be useful and could be relevant as we were preparing for the surge. And then saying, should we be successful in procuring or coming up with some supplies, what would be an equitable way of distribution? What kind of rules could we all agree to that would be ethical and fair and would figure out who needs these and how do we get a hierarchy of decision making about allocation of scarce resources. Next slide. And I'm very proud to say that the community came together and we did agree on the set of rules. So by March the 20th, we were in sort of full-scale operational activities. Two things were happening. At the community, we had identified the list of needs and said, okay, what is it that's in short supply? What exactly do our frontline workers, and this was a shared list created by public health, healthcare, emergency managers, first responders, et cetera. What are the most important things that we need to get? So we had a shared list. And then we did a widespread call to action to the community. And this is where our local university was brought into play early, Saginaw Valley State University, which is kind of geographically central in our region. And we told them we needed warehouse space. So we took over the athletic center at the university, and it became the warehouse of supplies that could be distributed through those shared rules. And this widespread call to action went to the community, to every corner of and every part of the organizations. And we secured this central location and said, we're going to collect everything in one place to allow us to distribute. Now, that wasn't a perfectly managed activity. There were a lot of things that were already en route and going directly to some organization like health systems. And then in the rural counties, we set up separate drop points because people weren't going to drive 80 miles to go drop things off at this one place. So the more rural counties had their own special drop points. And then the backbone organization, or Mahaya, that we were discovering our place, we were managing the warehouse, so to speak, sorting, creating inventories, the request processes, and managing distribution of those collected assets. Next slide. But it was very quickly apparent that we could the burn rate of those kinds of things wasn't going to allow us to be successful with just what we had collected at that warehouse, so to speak. Simultaneous to that, these are actually, all of this started before the state even went to a shelter in place. The shelter in place date was March 23rd. So as I said, we were operational before that, though, in the week prior. And in the same week prior, we had already started with local mask making by what I call the sewers, the army of the sewing guilds. These are the quilting organizations, the church sewing groups, and all kinds of groups, 4-H, you name it, that were the army of sewers. And we had come up with recommended patterns, processes for the sewers, drop points for that. We had purchased large quantities of supplies. This is before stores were closed. We had already gone and taken over things like Duran Fabrics and Michaels and collected all the fabrics and elastic and things like that, and came up with guidance documents about how to safely wear a mask, what are the recommendations, and distributed these to these homemade masks where there were gaps, and educated people on proper wearing, and came up with disclosures and laundering procedures and all of that. So this was a very large undertaking. Next slide. That actually has continued until just last week or this week. So tens of thousands of homemade masks were made and distributed. And this is the shopping that happened before the stores were closed, the assembling of kits to allow sewers with pre-made patterns and kits to make masks, and they were assembled like this. Next slide. And this is an example of something that happened not that long ago. There was a great mask giveaway, and this was more for citizens who, people in the state are being asked to wear a mask when they're in public, and as all citizens didn't have necessarily access to those, and as businesses and non-essential workers are starting to come back in just one county, We had an additional 30,000 mask giveaway project for one day here. So this is to get the scale of what was going on and the longevity of that kind of work. Next slide. As I mentioned, what we were able to collect from existing closets and supplies around the county was radically insufficient for the needs. It helped to temporize, but what was clear immediately was that we needed to be able to source these, that the normal processes that we thought might deliver these, whether they were coming through federal sources to the state who would then allocate them out, were not able to meet needs. So we immediately began to look at how could we self-manufacture within the community or find ways to do that, and came up again through this dialogue. We were meeting initially 3 times a week, where we would have all of the hospital supply chain managers, the public health department leaders, county emergency managers, everybody all from this group together on gaps and needs calls. And then clearly we focused on PPE based on everybody's needs, and began to engage local businesses and local universities in literally making those things. We would get spec sheets from the health system saying, what would you normally buy? Give us a spec sheet, what that looks like, and then would go and identify 1 or 2 or 3 companies who could either produce it themselves or produce that in partnership. Like maybe one face shields was an early example. One company could make the headband part and another could make the face piece, and those could come together and be assembled. We also had assembled the 3D printing assets in the community and inventoried those and brought together the people who ran those machines, and they began to do prototyping with 3D printers that could then be taken to companies who did injection molding or other manufacturing processes that could use those prototype documents or examples to be able to do that, and then bring those things to production volume. And as this evolved, we ended up, every single piece of the story started getting assembled into what literally became a catalog of, hey, here's a place that you can get this particular product. Here's another one, here's another one. Here's where you can get cloth masks at large scale. Here's where you can get face shields. Here's where you can get isolation gowns. Here's where you can get whatever. And it looked like a catalog, and we'll show you an example. The other thing was testing, and we began to struggle with the testing needs and sufficiency or lack of sufficiency of the supplies where people couldn't get test kits. And so we began to break that down, saying, well, what's in the test kit? It's a test tube with viral transport media and a swab. So how do we start making that? We get test tubes, we make viral transport media, and we have somebody make swabs. And literally we got the BSL-2 labs at the local universities who did reagent inventories of what they had on hand and pooled those assets, and we pulled from the CDC and FDA the exact formulas for creating viral transport media, and they still to this day are making that viral transport media being used by the hospitals for testing right now in our region. Next slide. So we're still self-producing, I guess, is the bottom line. So this is an example of some early 3D printing work where a couple of universities and a private sector company, we realized where all the 3D printing assets were that we could enlist. And just a couple quick examples. Next slide. And this is what an entry in the catalog, which became quite a long catalog. This was one of our first entries. And there would be several photos and descriptions and a spec sheet, just like you would get in any other product catalog, websites, phone numbers, emails, how to order, what the cost was, etc., if there was a cost. Next slide. And these are other examples out of the catalog from local manufacturers. We ended up with, by April 27th, we had 9 options for face shields. So people had several sources. Next slide. And then large-scale manufacturing that was being done of various mask options and assembly instructions. This is sort of a flexible mask option that was reusable by changing the filter materials. Next slide. So this is back to our space out at Saginaw Valley in the athletic complex in the Ryder Center. One of the other needs besides PPE was a huge need for hand sanitizers and cleaning materials. We had a local distillery, began taking their assets and worked with the university to actually formulate and bottle making hand sanitizer, which was urgently needed. And then Dow began to bring one of their plants online to the dedication of making hand sanitizer. And they began to produce large scale in multiple plants around the world, but in our community, we were getting about 400 gallons a week to distribute to our local hospitals. And it was being delivered by the National Guard. There was a safety data sheet. It was in our catalog, et cetera. And this was a donated product, so not everything had to be purchased. And these were all assembled, these little signs on the wall. That's each of our local hospitals and urgent care folks that were coming to pick up their allocation by our formula of fair and equitable distribution. Next slide. And then some new products that would come. So although we would meet gap space needs, there were even new things. This oxygen hood, or sometimes called oxygen helmet, as ventilators were in such short supply, there were news articles about alternatives to ventilators that could be deployed, and we were able to work with the manufacturer. And this is part of the prototyping process of bringing these in and saying, will this work for you? How can you use it? How do we modify it? What will make it better for you? And getting these shoulder straps was one of the prototype steps. Anyway, next slide. And this is the viral transport media being produced here in one of our local universities. And this is a typical production. They were doing about 1,700 vials per week. And we had tremendous cooperation of our local health systems for that. The geographically closest facility to the university was picking them up and storing them in their walk-in cooler under the proper conditions, and then the other health systems would pick up from that one. And so there was they became the distribution point for that viral transport media testing kits. Next slide. This is the story of creating the swabs. That became one of the most interesting journeys that we went on, trying to move from 3D printed swabs, getting the right material, the right exact measurements, getting the right flexibility of the raw material and testing an iterative process. And now this is being produced at scale, injection molded from a manufacturer in Michigan and filling the needs along with the CMU viral transport media. Next slide. And then as we worked for so long with the essential workers but then as the state begins to move to opening and the gradual reopening, then the non-essential businesses and their needs came into play. And so we created a separate catalog of some of the materials most relevant to the non-essential businesses, and that's online and their capacity to use that to get their needs met as well. Next slide. So at this point, I want to go and let some of the voices of the community sectors that were involved in this process give a little bit of the insight from their seat. So I'll turn this over to you, JJ from Saginaw Valley.
Thank you very much, Kathy. Pleasure to be joining all of you this afternoon. As many of you may not be familiar with our university, Saginaw Valley State University is the youngest of Michigan's 15 public universities. We are located in the region that Kathy showed on one of her earlier slides. And community engagement is really part of our DNA as an institution. It's been at the heart and soul of what we do for a very long time. And we are nationally recognized as a community engaged university by the Carnegie Foundation for the Advancement of Teaching and Learning. So when there was an opportunity for us to rise to the occasion and try to support our community, we were eager to accept that challenge and do our part. Next slide, please. And as Kathy showed earlier, one of the things that we were able to do was quickly take advantage of our very large space with our primary athletic facility, because there were no intercollegiate athletic contests during this time period. And so we were able to clear out from some of our athletic equipment and basically transition that into a big warehouse that was available for people to drop off medical supplies, to pick up medical supplies, and to have that be a resource to the entire region. Next slide, please. Oh, if you could go back one. Yep, thank you. And as Kathy briefly mentioned earlier, we had a local business, Old Town Distillery in Saginaw, that had a few hundred gallons of alcohol that were originally intended for another purpose, but they decided to make those available for us to use and take advantage of our expertise and our facilities, and use that to make hand sanitizer that, as Kathy mentioned, then was distributed throughout our region. And we're also grateful that we had that opportunity, because you see Vincent Flores there, one of our students, who was among those that was able to also make this a learning opportunity to be part of that process. Next slide, please. One of the other things that we recognize is that the virus created many health threats. It also created difficulties for people who had mental health issues or substance use disorders and also needed to have treatment. So one of the things that we did is we had Project Echo that already was a great resource for people in those spaces to be able to provide services and to increase the telehealth services that were available for people within this large region to be able to access medical care virtually for continued treatment of those issues, knowing that they could not go into their primary care provider the way that they normally would when Michigan had its stay home, stay safe order in place. Next slide, please. Another one of our rules as a regional public university is to prepare graduates who are from the region and who stay in the region to serve the region. And so we have nurses and doctors and engineers and teachers and first responders and many others who have been on the front lines of this pandemic every day from the outset. The first public testing site that was available in the Great Lakes Bay region was headed by one of our nurse practitioner alumni. And again, engineers who normally are making roofing materials were suddenly transitioning to make PPE equipment and things of that nature. And we're very proud of the role that our alumni played in quickly adapting and responding to the challenges our community was facing. And one of the more interesting and innovative aspects that SVSU is involved with currently is that we are drawing upon our relationships with local public health departments, and we are now in the process of testing samples from wastewater treatment facilities to determine if any COVID is able to be detected in those wastewater samples. What we learned is that a community in Massachusetts was able to identify a surge in coronavirus cases by testing wastewater prior to that showing up through conventional human testing. And so again, we have the brain power and we have the expertise and equipment to be able to do this kind of testing. And so we are now doing that in partnership with several local health departments within our region, again, to see if we may be able to detect a rise in cases before they would show up through other means of testing. And we're also exploring if we may be able to adapt this for use on our own campus and test the wastewater coming out of our campus as we anticipate students returning this fall. And I'll return it back over to Kathy at this point. Thank you.
Okay, so there were also recipients of all of this work, and that was the health systems. And they were incredible partners. We needed them. We needed everybody. We needed these manufacturers. And one of our most challenging discussions was the day that the health systems were asking us to find somebody to make body bags. I think we all were in tears to know that we needed to make more body bags and find somebody who could do that. And that was one of our first, was again a roof manufacturer who was stepping up to make body bags, and others did later. But without the manufacturers and the universities and the health systems and everyone working together, we couldn't have pulled this off. And we needed the health systems and the clinicians in those health systems to be doing that prototyping and support. So we're going to have a voice of the health systems telling us what the world was like from their experience going through this.
Okay. Thank you, Kathy. My story is really going to try to convey the good, the bad, and the ugly of the past few months, but let's focusing on the good and the collaboration that we saw. You know, we like to say around here that it all started with toilet paper, and around the time that we saw the panic buying, we were starting to see the slowdown of Chinese source supplies. Overnight, it seemed that, you know, the PPE items, the demand for those were just going off the charts. Things like the masks, the gowns, the wipes, the hand sanitizer. We soon started hearing about hotspots, and before long, we saw that they were popping up and all around the country. And we didn't know what we didn't know. Nobody in our organization or what we had heard around the region had ever been through anything like this before. And the fear of the unknown, at times, it felt somewhat paralyzing. You know, we heard that it was starting to hit Detroit, and then we were concerned how fast it could move north into the Great Lakes Bay region. So we rolled up our sleeves, we got to work, and we started prioritizing our needs. But we saw some bad in this process. We saw bad in the form of greed. Greed as prices started to climb exponentially high as the demand for the supplies rose. An N95 mask, for example, that we might pay 50 cents for in normal times was going for $6.50 in early April. We saw ugly in the form of theft. Small stuff, you know, masks and gloves, but it was still theft. But the good, from our story, the good was the local community. As Kathy mentioned, local communities were reaching out to us and what could they do early on in the crisis. And so the donation of hand-sewn masks, disinfecting wipes, and other cleaning supplies from schools and churches really started the collaboration and the good of the story. Next slide. From the healthcare facilities in our region, who I get to represent, you know, good was really the collaboration with our business partners, with universities, and with associations like the Michigan Health Improvement Alliance. These collaborations really enhanced our ability to get at the needed supplies. Collaboration with the local small businesses like the Old Town Distillery, producing the hand sanitizer with SVSU and bottling it, and then the further collaboration with Dow and retooling their Auburn plant to produce and package hand sanitizer. All of this allowed us to keep our system and those in the others in the region supplied in hand sanitizer throughout the height of this crisis at no cost. Significant contribution or collaboration. For Mid-Michigan in particular, Dow, one of, you know, obviously our local partner here, Dow provided us with more than just supply of products. As our need to supply directly from China became more apparent because of rising prices and lack of supply, Dow actually provided us with contacts in the Pacific region to allow us to get closer access to those supplies. In addition to that, they gave us process support, you know, so that we could make sure that we were properly navigating this complex import process and doing it effectively. And just as a side note, collaboration really knows no borders. in order to make sure that we could effectively buy these supplies from China, I actually became a member of Alibaba.com, which is China's equivalent to Amazon. And there was an Alibaba manager who happened to be a former Dow China employee who became aware of our need. And because of that tie to Dow and the tie to Midland, he was our focal point and guided us through the entire purchasing process from China. And without his support, I'm not sure it would have gone as smooth as it did. And then there was further collaboration, evidence of that recently to help supplement our N95 supply issues. You know, 3 giants in industry, Whirlpool, Dow, and Reynolds, designed, developed, and then donated almost 200 PAPR respirators to help protect us and our employees here at Mid-Michigan. Next slide. You know, Kathy talked about a lot of work that went into the testing supplies, and you know, at the time, FEMA was pushing much of the testing supply capacity to the hotspots. And so this lack of access to the testing supplies was affecting our ability to properly test our patients in the region for the COVID-19 virus. But through Mahaya collaborative relationships, we were able to secure the 2 key testing supplies that she mentioned. You know, with Central Michigan University, Fire Up Chips, we secured viral transport media and were able to distribute that to all of the region systems. And then probably more amazingly with Centrix, who is a dental equipment manufacturer in Connecticut, our Midland lab here at Mid-Michigan was integral in helping to develop and prototype the testing swab, which we are actually now using and receiving on a weekly basis. Next slide. And then a flood. And not just a flood, but a 500-year flood, and the collaboration continued. Local businesses, the night that the dam broke here up in Edenville and then in Stanford, these local businesses came in and helped support us by providing the labor to help us clear out our storeroom, and we made it just in the nick of time. And then, you know, a week or 10 days later, these same business partners came in and helped move all of our supplies into our new temporary warehousing home out at the Midland Mall. So, you know, from a Mid-Michigan standpoint, but also from a regional healthcare standpoint, thank you just doesn't seem to be enough for all of this collaboration. But I do know that we all, as healthcare professionals, we are truly grateful. So thank you very much. Kathy?
Next slide. So you mentioned the flood, and I want to reinforce one of your most important points, that there were donations and there were manufacturer retooling and all of that, but there were a lot of intellectual property assets and just experience coming through. And a near unbelievable experience that came in on May 17th that started with a lot of rain, up to about 7 inches of rain in our counties in a very short period of time. And then there were a series of dams. We had 2 catastrophic dam failures that occurred and immediately put about 10 feet of water across the region. It literally drained 2 lakes into the cities and to the surrounding community. And in a very short period of time, there was an immediate evacuation of over 10,000 people. And the damage is still being assessed, but it's extraordinary. And this still goes on. We aren't even close to the cleanup and the complete restoration of this. So we're still persevering through this period. And as you can imagine, where we're still trying to manage social distancing and PPE and the difficulties, and the hospital that Chris is in was in the midst of this flood, and they're trying to save these precious supplies. But the Midland failed dams, you can see a news article here, $200 million in damages already announced, 2,500 buildings destroyed over 150 homes, and that were completely destroyed, over 790 with major damage. And most unfortunately, only about 8% had flood insurance. These were not in a normal floodplain. These were places that flooded due to dam failures. And so as of June 5th, there were still 800 customers with no phone service, over 500 without access to broadband still, and over 300 who now were having dry wells because of the complete change of the water table. We have a very short video to illustrate the moment of the dam failure here. We're going to play this for about 2 minutes so that you can see going from how this devastation washed over the community in a matter of hours. I'm not sure we have the sound. But here goes the water. So the challenges of this are when you have a flood so instantaneous and tens of thousands of people displaced from their homes, and you can gotta keep going while I'm talking here, but there needed to be shelters, and you were still trying to do social distancing, and how do you manage all of that and try to keep from having a significant outbreak of virus. So we're going to tell a couple of stories. So Dr. Kikano actually lived in downtown Midland in a condo there and was involved in some of the shelters and the work there. And he's going to just give a few points of information. If we can go back to the PowerPoint, we'll be able to share sort of how that came together, simultaneous flood and pandemic.
Thank you, Dr. Bazzi. Like everyone else said, we've been dealing with COVID-19, and you get a flood of water that happened literally in a couple of hours. Most streets get flooded, and with no signatures where to go. So within a matter of few hours, there are multiple shelters that came out in the community just from the grassroots level. Sorry, can you hear me? Thank you. So one of them, we have one of the large high schools in Midland became a shelter. So in the matter of few hours, the Army Corps of Engineers brought in 150 seniors to the gymnasium that you see. We used initial costs from the high school. So 150 from the local, some senior home facility by the river, others evacuated from their homes with nothing. No medication, no cell phones. As a shock to myself and others, some of these seniors had landlines. So who's your daughter, who's your son? They had no numbers for them. So what we did, obviously, C-19 was front of mind for us. So we have one local hospital that got flooded. So we pulled our medical students from the hospital. We pulled nurses from the clinics and an army of volunteers, not just healthcare, from all sectors, senior by senior, checking on symptoms, food, dehydration, or others. Call the local pharmacies to, we have Mrs. Smith, she needs her heart pill, her sugar pill, give us the list. So volunteers, as a physician, we called their medicine, volunteers went and picked it up and paid for it. The superintendent of the high school, the principal of the high school called the seniors who were about to graduate to come and do sanitizing for the halls. So we got an army of seniors from that same high school came on the listserv, sanitizing everything, beds, doorknobs, counter services. And more importantly, the lineup, there's a big drive in front of the high school. The local community volunteers dropping, just popping up their trunks without getting out of their cars, brand new supply. They were not cleaning their basements. They were bringing food, pillows. We had pet food. We had food, to feed an army for a month. Board games, books, name it, we have it. The other evacuees have been either coming in with families, so we put them in the classroom. Anyone who came with the family had a classroom. We had few who came with pets. Again, we put them in classrooms. Just to illustrate one example outside the seniors, we end up with a young lady with severe mental health issues, 31 weeks pregnant, boyfriend there, brother there, no prenatal care. So found out all three of them are homeless. This is homeless in a smaller community. One of the volunteer nurses with 2 students, 6 hours later, the 3 of them had a shelter. We provided prenatal care for her on site. We identified the physician practice to take care of them. Before they left, she had a car seat, she had a stroller, she had baby clothes. So outside dealing with acute issues, we end up dealing with social issues that were happening as we speak. So the local veteran chapter came in, screened volunteers who are vet connected, connect them with the local VA. One of the national carriers, I have not Verizon, Sprint, or AT&T, unsolicited brought a big truck for satellites. So we had internet for all the residents there. We had chargers for their cell phones and cell phones. And obviously, because of the concern about C-19, we are 3 weeks out. Happy to report I was with the public health director this morning in the region. We've had 0 C-19 cases. 4 days out, we found a place for everyone to come to their homes, to their family, if they had a home, to their families or senior centers. So the operation went seamlessly. The number of volunteers we had were turning people away for night shifts. Sign up from 7 p.m. to 7 a.m. People wanted to help. So they helped in time, they helped resources. It was well coordinated. And we were one of 3 or 4 shelters in the region. And happy to say no C-19 cases and not a single death from 10,000 evacuees. Thank you.
Okay, so let's move on to the next piece of that story, which is also the private sector, the business community, and their extraordinary capacity to make a difference in both COVID and in the flood at the same time. So Rebecca, talk to us about Dow's role here.
Will do. Thanks so much, Dr. Bazzi, and thanks to the fellow panelists. It's a real honor to join you all today and share our story. So I represent Dow, and for those who might not be familiar with our company, we're one of the world's largest materials science companies in the world. We have about 36,000 employees located around the world, and we operate in more than 100 countries. But we are headquartered in Midland, Michigan. That's where our founder built our company 125 years ago. Our ambition is to be the most innovative, customer-centric, inclusive, and sustainable material science company on the planet. And it's a work in progress, but this is a great example of how we approach collaboration and partnership in our communities. So let me talk about COVID first. As an executive team, we recognized early on that COVID-19 was going to have a big global impact. We have colleagues and operations in China. And so from the very beginning, we had a crisis management team that began meeting in January to assess and address the impact on COVID-19. And we have not stopped. That corporate crisis management team still meets weekly and will continue to do so until every single one of our offices and operations have moved through the pandemic. Our focus from the very beginning has been on the health and safety of our employees and the resiliency of our communities. And as I mentioned, we have 36,000 team members of Team Dow around the world. About 14,000 of those colleagues have been operating our manufacturing facilities throughout the crisis, staffing plants and laboratories to manufacture and ship vital products and technologies that are really needed to power the world.
Please. We need one slide.
Oh, yep. Are we still on the old slide? Yeah. Thanks for calling that out. We'll go one more, couple more. There we go. That's it. Yeah. Thank you for that, Kathy. Got so busy talking, I didn't glance at the slide. So here you see actually the examples of the products and technologies that Dow makes that support the healthcare and hygiene industries. We also had another 22,000 team members whose roles allowed them to work from home. And so we've been taking a number of actions to protect the safety and well-being of our team members on our sites, implementing very strict hygiene practices and taking every possible precaution to protect each member of what we call our Dow family. A few things I wanted to highlight that I'm particularly proud of that our company did was institute a global minimum paid leave for those who have COVID-19 or who are caring for someone who is ill. Out of a population of 36,000 employees. We are right at about 150 employees in total who have contracted COVID at some point over the last 6 months. So a very small number, and we are also able to track and determine that in no instance, was there a big outbreak at one of our facilities. And so we continue to really lean on the strict hygiene practices to keep everyone healthy. But in the instance of somebody either contracting or having a family member who does, we have a global minimum paid leave. We also recognize that we had thousands of colleagues who were continuing to report to our sites and who needed help with dependent care. And so our team put in place a number of dependent care mechanisms to help those team members. For our frontline workers, we provided a special recognition cash payment to recognize their efforts. And then we also elevated, reinforced, and we encouraged the use of resources like telemedicine and our employee assistance program, recognizing that stress and anxiety certainly are on the rise around the world. And when folks are working from home, there's a real risk there. If we go to the next slide, please, I'll talk for a minute about how we adjusted our manufacturing to address some of the supply chain gaps that you've heard from the previous speakers. So from the beginning of the pandemic, our scientists and technical experts were really eager to utilize our materials and technology to help fight the spread of the virus. You heard the hand sanitizer example. We actually converted capacity in 5 locations around the world, in the US, in Latin America, and in Europe, to begin manufacturing hand sanitizer. We don't typically produce that. However, we recognize that a large portion of the raw materials that are required in hand sanitizer were readily available at our sites. So we completely flipped our manufacturing process in order to be able to make the hand sanitizer, and then had really close partnerships with suppliers, as you've heard, state and federal regulatory officials, to get that product moving quickly and into the hands of the health systems and government agencies where we donated for distribution. We partnered with Whirlpool and Reynolds Consumer Products to create respirators for frontline workers in healthcare. One of our scientists actually developed a face shield design, a simplified design for face shields. Dow made 100,000 of those and donated them to the state of Michigan. But we recognized that the need was far greater than 100,000. And so we actually publicly shared in an open source file our IP to the world to accelerate production for anybody who wanted to make the face shield and help close the gap on supply. And then also medical isolation gowns. To address the ongoing demand for single-use isolation gowns, our team designed and produced a level 2 isolation gown from all polyethylene resin in less than 4 weeks. If we go to the next slide, please, maybe one more comment on COVID, which is our return to the workplace playbook. So we recognize work is continuing.
There.
Oh, we're bouncing around too much. Yeah, there we go. Thanks, Kathy, keeping us on track. As work continues toward more widespread testing and the development of a vaccine, we recognized we really needed to plan for how we bring folks back to the office safely. We have a medical team on staff in Dow. In fact, Dr. Bazzi was our chief medical officer for about 20 years. And so she knows that team really well. It's a team we're very proud of, remarkable professionals. And so we worked with them and our environmental health and safety team to ensure that we had really good precautions in place for how we return folks back to the office. And again, in the spirit of sort of open sourcing ideas, we created a comprehensive guide, and then we made it available on Dow.com for anyone in the world to download and take whatever tips might be relevant for their workplaces and make them their own. We had 1,300 downloads of our playbook in just 2 weeks, as other companies, nonprofit organizations, and academic groups took advantage of the tool. And, you know, we continue to share our approach and best practices. We believe that we learn more by the process of sharing with others, and we learn also from others as well. And it's important that we work together to ensure the health and well-being of all of our stakeholders. And so then I'll just go to one more slide and make a few comments about the flood. So as you've heard from those joining me on the panel, we had thousands of people across the Great Lakes Bay region, including our own Dow employees, who are facing unique and big hardships in the midst of COVID-19. There aren't many global companies left with hometowns, but for Dow, the Great Lakes Bay region has been our home for 125 years. And so when this flood took place, our global supply chain and our customers and partners from all over the world jumped in to help. So we certainly had colleagues and friends and neighbors that were dealing with damaged homes and trying to pick up the pieces of their life after this disastrous event. So from a Dow perspective, you know, what we did, we announced $1 million of support for immediate relief and long-term recovery efforts. We established an employee assistance fund with a $250,000 donation to really help our employees cope with unexpected hardships that have put financial stress on them. Kathy mentioned the vast majority of families, insurance is not covering any of this. And so we're, you know, looking to help close that gap for our employees, but also in the community. And then one of my favorite things that speaks to the spirit of collaboration was the way in which our network of global partners and customers and suppliers worked with us to source donations. So we received donations from all over the world, and they arrived by truck, they arrived by plane. Within Dow, we have our own aviation team, and we have access to airplanes, and we put those planes into action. We were flying up supplies donated by employees and communities on the U.S. Gulf Coast. We used our aviation hangar in Midland, Michigan as a distribution center. We had a customer, Olin, that delivered 4,000 one-gallon jugs of bleach in 24 hours. Nestle Waters is another big customer of ours. They donated cases of water, 140 pallets of water. Kellogg's, Frito-Lay, all of these great customers of Dow jumped right in and said, what can we give you and how quickly can we get it there? And so then we put our supply chain experts to work. In partnership with local officials and the United Way and other nonprofits, we established 8 flood relief centers around the region. I mentioned we used our Dow hangar as a distribution hub, and we ran those relief centers to get critical supplies, bleach, shovels, garbage cans, food, into the hands of people who needed it most. Our Dow employees dedicated 7,000 volunteer hours in 2 weeks following the flood to support those relief centers. And we're continuing to partner with the United Way and these other agencies to keep getting the relief materials to where they're needed the most. So I'll just wrap up by saying I'm so inspired, not only by what Team Dow, but our community partners, as you've heard from here on the webinar today, are able to do together in times of crisis. And I just think it's a really awesome example of resiliency and innovation and working together through challenging times to help our communities. And so with that, Kathy, I'll turn it back over to you.
Okay, great, thank you. And we're getting close to moving on to questions, but right here I'd like to speak to that this story continues. It's not just about the first window or the first few months of COVID-19 and the flood, that we were already working through our Thrive initiative and the broader collaborations that I opened the meeting with to address a large number of issues. In addition to managing supplies and all of those other things, there have been other things. There have been hosted serial webinars where we were bringing together the community to learn together. And you can see these are just a few of the cover slides from those. In March 25th, we were hosting what is this thing, the coronavirus? Is this really a big deal? What might happen? What should we do? A session for a whole host of stakeholders. In May, we had an update. In June, we had a safely opening, in that as the community was evolving to begin to open non-essential businesses, we were riveted on how do we make sure that people have planned and moved into that space of the new normal in the safest possible way, and the high readiness state that we were enabling. This is a pop-up sort of response. This was a quick call that we had lots of people that had been displaced from their homes in the upper right-hand corner, and there was an acute need for personal hygiene supplies that call went out one day, and within the next 24 hours, there was an assembly going on of people that just had left their homes with nothing, and we had them placed in various places in hotel rooms and other things, but there was personal hygiene products assembled. So the work goes on, and there's a whole lot more to recovery. One point I wanted to share is over on the left of this graphic, it says faith-based community, and this document was put together and distributed in the early part of March. And in particular in Saginaw, which is our most populous county of all of this, it has a high density of minority residents. And there was a lot of concern as we were learning about the vulnerability of some of these populations, and worked prepared materials with partners in the faith-based sector and get this out about what were the right things to do for our church goers and the pastors, and worked with the pastors to disseminate this information very, very early, and talk with people about what really needed to happen here. I don't think that this gets the credit for that, but I'm happy to report that in Saginaw, we have not seen the disproportionate adverse impact on the African American community that has been so prevalent in so many of our other communities. So there was a lot of people doing some great work in this regard. Next slide. And so as things go on, I mentioned this Thrive initiative has been going on now, and we're in year 3, 2 years of sophisticated planning and 1 full year of implementation now. The purpose of this is addressing intractable challenges that seem overwhelming and bringing everyone together to do that. In that regard, we've really reflected in a serious way about what would be out of our portfolio that was previously determined of 34 items. At this point in time, with coronavirus, with health and economic challenges associated with that, with the flood and the widespread devastation it has brought to our community, and with the challenges of racial harmony needs and understanding what would be the right things to go do. So each year we pick another package of that portfolio to go forward. Next slide. And in this regard, using some wonderful tools from Collective Impact, the Kaiser Foundation, NASDO, the National Alliance on Social Determinants of Health, etc. This is the focus of our community going forward, looking at what are those things that are going to need the greatest amount of attention that were already in our planned portfolio, and that's education, food, financial stability, and each of these is a pretty big bundle of actions. For example, in financial stability, that's health or financial literacy, poverty efforts, etc., and strengthening primary care and care coordination. So these fit with the great needs that are only magnified during this time and will continue to go forward. In closing, I think our experience reinforces the fact that every complex, big challenge needs multiple sectors. There is nothing we're trying to address, whether that's obesity or poverty or food insecurity or any of the things we were already working on, that they are not possible to solve by one sector or one institution under any circumstances. And the experience of a crisis reinforces that health and the economy do go hand in hand, and that the contributions of many make really devastating situations a little bit better. And this is all built on relationships, trust, ongoing partnerships, and having that kind of a framework, history, dynamic in the community is an incredible asset. And having the sort of framework of an integrator or a backbone organization and those kinds of things can be brought to bear and to turn on a dime to walk into new roles as needed. So we'd like to open this up for questions, and I think we've got some in the chat, but I know, Bob, you're going to coordinate the questions, and our whole team's here for response.
Great, ready to go here, Kathy. And thank you so much to you and your team for a fabulous description of how you prepared for this and responded, and truly inspirational. So yeah, we got a few questions here. Please use the chat box if you have comments or questions you want to bring forward. One of the first, I think probably would go to you, Kathy, and I think maybe Christopher as well, related to PPE. And you mentioned, Kathy, a process of I think conducting inventory of assets, including of PPE. And so the question was wondering, where did you find gaps? And I'm going to add a little corollary to that. We've heard, certainly since the beginning of this time, that although hospitals got a lot of attention, long-term care facilities, prisons, meatpacking plants, homeless shelters have been areas that have not certainly been in the news as getting some of this PPE. So if you could address this issue of how you identified gaps in PPE and whether or not any of these other institutions were identified.
Well, how we identified them was we asked people what they needed. And as I mentioned, we started with a series of meetings that we would assemble all of these people several times a week and ask them, the county emergency managers who, you know, are running the emergency operations centers for the counties, the health department leaders, the supply chain managers for the hospitals. We were meeting and including the needs of first responders, the ambulance companies, the EMTs, the law enforcement professionals. We don't have any meat packing plants that I'm aware of anywhere in our region, but looking at anyone who was in a first responder situation with a hierarchy of health and just saying, and to be honest, to some degree, I felt like we were in whack-a-mole sometimes. People, the first thing was like, oh my gosh, we've got to have more masks. Okay, we're rallying around masks and we're getting them. And then the next time we have a meeting, it's like, you know what, we've run out of, or we're about to run out of the next thing, isolation gowns. And the next biggest need we have, and it wasn't like at one moment we had all needs identified. They kind of cropped up on us a piece at a time, and it was sort of like the serial meetings kept unveiling the next thing to go tackle. And then one day it was thermometer probe covers. Hey, do you have any idea where we could get in the hospital? We're running out of thermometer probes covers and we can't get any. And it went like that. It was, and each meeting we would say, what do you have? What do you need? And we were trying to also calculate burn rate and monitoring the case evolution. So that was pretty much how we defined it, is by asking people and listening. I mean, literally, it was that straightforward. What do you need? And then talking to the emergency managers, and we had our inventory, and we would give the inventory of everything that was out at the athletic complex out at the university. This is what we have. If you still need that, go get it from that place. You know, we had 100,000 gloves sitting there at one time. And if you need gloves, go get them there. Otherwise, here's what we have and what we don't have. And then it was the manufacturing process. And your second question.
Well, let me actually add to that. The issue you brought up, I think, Chris, you were talking about some of the ugly, and that is the greed and theft that you noticed. And so one of the questions was how did you deal with that? Did you publicly call people out? What was your approach to managing that issue?
Yeah, I mean, from a theft standpoint, we didn't publicly call people out individually, but we did bring it up in meetings. You know, we were run with incident command centers, and so, you know, we have daily safety briefing meetings here. And so we would just, you know, alert people that we were trying to conserve PPE and we were being as politically correct as we could without calling people out. You know, from a greed standpoint, there really wasn't a lot we could do. I mean, we could have inundated the Attorney General's office with a lot of these, you know, price gouging type of situations. But that's really where we started to say, okay, we can't afford to pay $650 for an N95 mask. So what can we do to substitute for that? And that's how we got into Alibaba.com and going straight to China and working with Dow on the you know, the processes and contacts to get there, using face shields and regular masks instead of, you know, having to deal with the N95. We got creative and started using UV technology to start disinfecting our N95 masks and using perhaps STERET processing that some universities have done. So we tried to get away from the greed by looking for alternatives, and Kathy's team was instrumental in helping us get there.
Great, thank you.
What we did with the things that were at SVSU, when we did assemble them, our original design was, hey, if these things are that hard to come by, we don't want to place any of this precious stuff at risk of theft or loss. And so when we identified the location at SVSU, we talked to the executive leaders there and said, this needs to be a lockable facility with controlled entrance where there's got to be under video surveillance, et cetera. And what we had was the police of the university police actually controlled access to that. And there was a, the way to get in there was not released except for people had to get a request for those supplies. And then we would release the phone number that they needed to call for the police to be able to get access to those supplies. So I don't believe we had really any theft through that process, but that was anticipated in advance.
Great, thanks. So you've mentioned in passing incident command. I think many of us are familiar with that structure. And so one of the questions is, how did you coordinate with incident command? And was there any turf issues, resistance in your work, their work? How did you integrate?
Yeah, well, here's an interesting question, and it goes back to my one slide where I said in March, the week of March 10th to 15th, we were trying to sort all that out and saying, well, you know, we kept getting questions and pleas from myself and Martine to step in and help, and we kept thinking, well, what could we actually do that we're not getting in someone else's job? And that's why we had these conversations with the emergency managers of what is it that you're doing and what is it we could do that would be constructive and helpful to you? How do we help you be successful? And we talked to them and said, we'll collect this stuff. We know that people are supposed to contact the emergency managers for their supplies. If they contact you, do you want to direct them to the inventory or give them access yourself? Do you want us to handle that process? And we just worked that out in a collaborative way, being very sensitive to the fact that they lead on that, but they were the people asking us to help. And so we were stepping in only where we clearly had those discussions in advance to say what would really work here for everybody. And you guys tell us, we'll manage the inventory. If you'd rather do that, you can do it too. But most of the time it was, they were appreciating the hands and feet and the support that they were getting from our team and trying to keep it clear in one sort of system approach. So they were in one process of decision-making and communication on roles and responsibilities for those.
Thanks for that.
Maybe if I could just...
Go ahead.
Yeah, go ahead, Dr. Kirkani.
No, go ahead.
Okay,
go
just
ahead.
quickly. Thank you. I was going to make a comment on more incident command on the flood side. You know, I would say this is where the power of community partnerships and strong capabilities at the local level comes through, because that was coordinated at the local level and with the support of local partners. Anybody in the community who was waiting for the feds to come in and help would have been waiting a long time, quite frankly, and in some cases might still be waiting. So it was definitely evident that local partnerships and local capability to run those incident command centers in the case of the flood was the success factor. And I don't know if any of you who are participating here would disagree with that or have a different point of view, or Dr. Kakano, you were going to make some additive comments.
I agree with Rebecca. So at the more grassroots level here, I mean, for the brand new shelter, one person, I mean, retired executive who had disaster management experience. He was the person in charge, handled things amazingly well. I mean, this is the food team. These are the donations. This is the donation team. These are the health team. He put like more of an org chart on the wall in the high school, assigned people within their expertise of domain. If that person has left that shelter for 36 hours, maybe, I mean, he worked amazing. I mean, decision making, very, very professional. Everyone followed commands. I mean, it's an army-like thing. It worked beautifully well, but there was one person in charge.
Thank you. Kathy, one of the things at the end of your presentation that I think struck us all, and there's a question about it, and this is, the headlines are about the disproportionate impact of COVID or floods on vulnerable populations. You mentioned something about the faith community and how they were helpful. And the striking epidemiology, I think, was that you did not note that disproportionate impact. So can you just expand a little bit more on that in terms of what would you tell other communities about how you went about doing this?
Well, I don't think there's been an official study, but the health department and others continue to report that very hopeful message that we have not had that experience of the disproportionately negative impact on those populations. Now, what I would say about the faith community is how valuable they are. And this goes back to sort of public health 101 and trusted messengers. And so, you know, getting the information out to the masses and having that delivered through truly voices of trusted partners, and having the pastors come together and that service the African American community and were trusted voices and could get the message out to them, and to look at the practices that they were going to be using and the messaging that was going to get out. But to me, that's just really important public health kind of considerations, is convening those trusted voices, working through them as partners. And it's just another dimension of the multiple sectors coming together and how important every sector is in this kind of process.
Great, thanks. Another question that's come in is with respect to waves of the pandemic, and we're all on the edge of our seats, as some states are still very much in the upswing of the first wave. The first wave isn't really over. We're also fearful of what's going to come next. And so there's the second wave of COVID, but let me just add a little bit more detail to that. And perhaps, George, you want to weigh in on this too. So in the midst of the dramatic acute requirements in responding to very ill people with COVID, there's been a postponement of urgent care, of elective surgical care, of the need for rehab, post-ICU, for chronic care delivery, and indeed for the expected post-traumatic mental health issues. So I'm wondering how the community is thinking about all of those things, from surveillance for the potential upswing of COVID in your community to the kind of some of the routine health issues and the severe mental health crisis likely to be ahead of us.
As states lift the stay-at-home orders, I mean, it does not mean the virus is gone. I mean, we have floods, we have other issues. I mean, you have racial issues going on in this country now, but the virus is still with us here. So what we call the non-pharmacological measure, that physical distancing, face mask when you are indoor, avoiding big gathering. No graduation party, no weddings at this point. Hand washing, these are measures that are going to stay with us for at least a year. So what we're seeing, the upticks in certain states now that either opened up early or had no restrictions. Most of these upticks are coming from Memorial Day, study testing issues, Memorial Day gathering and celebration. We're gonna see another uptick now from in cities where the protests happen with no social distancing. Most of them have face masks. Epidemiologists are still predicting another surge sometime in the mid-fall, October to November. But on the medical side, there's lots of good indications that we're going to have a vaccine that's effective by December. There are at least 3 clinical trials in the US that are going into phase three. So safety has been determined. Its efficacy at this point, they'll be testing July, August, early September, analysis October and November, and I'm very confident we'll have a vaccine in December.
I would add one comment that each of our major counties, the ones that are more dense population, have meetings at minimum once per week of the school superintendent, the civic leaders, the health department, the county foundations, and all the United Way. All these people gather, and I personally have been sitting on those calls as well for the counties. And there's this constant dialogue of how are things working, what's needed, how can we help each other, and that continues to go on. And the conversation about the second wave and preventing that, the local chambers and the economic development agencies and all have been convened to help push that message to the businesses as they're opening to make sure that they are prepared and planned. And if you are on the website of our local chambers or the economic development agencies, you'll see that there's this tremendous push of being prepared monitoring. Today, there was a meeting of dozens of business leaders, and they were talking about the symptom tracker that businesses can use that's put out by the state to help be in that early identification window of any outbreak. And so it's those kinds of tools of constant communication and messaging and collaboration around those things are still going on.
Great, thank you, Kathy. Well, we do have more questions and comments, but unfortunately, I think we are just at the top of the hour. So to respect everyone's time, I think we probably should bring this to a close. Let me remind everyone that the slides and recording will be posted, so you can presumably share this with other people, as well as look at some of it again yourself. And that the next webinar is also going to focus on a COVID-19 response of another community, Live Well in San Diego, which, similar to what we heard about today, had existed well before the pandemic hit. And that'll be posted on our website and going to take place sometime during the week of July 20th. And then one other thing, that there is an upcoming event from the Roundtable on Population Health Improvement for a virtual June 24 to 25 workshop on the topic of rural health. So with that, I think we're going to need to close for today. Thank you again, Kathy, for organizing this, and all the panelists for joining us today. Truly inspiring and apparently very effective community response. Thank you.
Thank you.
Thank you, everyone.